Respected Chairperson, distinguished panel of experts, learned audience, Assalamu alaikum and very good afternoon. First of all, I thank the organizer for giving me the opportunity to present the case that I am going to present on behalf of my mentor, Brigadier General Nuna Fatima, who was the operator of this case in this, at this August IPDI CARDIOCON 2022. Since the first description of an interventional procedure in the field of congenital heart disease by Rashkin in 1966, the non-operative treatment of congenital heart disease has made enormous progress. Intravascular or intracardiac stenosis occur in many forms of congenital heart disease. Therefore, the implantation of stents has become an accepted intervention procedure for stenotic lesions in pediatric cardiology. The case I am going to present is a young soldier who was full of life and vigor, suddenly became sick and found to have hypertension with an identifiable etiology that led to the implantation of a stent. My patient, Samuel Basher, 21 years old, reported with palpitation and profound weakness following physical exercise last year in April. And he was found to have hypertension, which was not manageable with multiple antihypertensive. For that, he was under evaluation, and initial investigation revealed normal findings. So the diagnostic catheterization done at adult setup and found normal. Suspecting the case is probable a case of coarctation aorta, the CT angiogram revealed that there is a discrete narrowing about 80 to 85% just distal to the subclavian artery. So the initial plan was to stent the quark segment, and if required, the second stent will be placed at the origin of the left subclavian artery to keep the patency. But in the cath lab, as you know, that there are some limitations, and also as well for the nature of the military service, there is medical disposal, and also the balloon angioplasties have a better result in young adults. So the decision was made to do an angioplasty. So as you can see, there is a very discrete narrowing with post-stenotic dilation just distal to the left subclavian artery. So initially, the quark segment was dilated with a high-pressure GMAT balloon that is 12 into 4 millimeter. Then serial dilation was done with Taishek balloon of 16 into 3 millimeter. As you can see, we are happy to see the intricate flow through the quark segment, but the very next morning, we are unhappy because the Doppler gradient, we found 50 millimeter of mercury. So the decision was taken again to take the patient to the cath lab again, and after the 3 months in the October, the patient was taken to the cath lab, and what we did that after the femoral and the radial axis on the left radial artery, the angiography done, and as you can see, there is still some intricate flow, but the gradient was more than 50. So what we did, we choose because it is at the site of the isthmus, so we have chosen a covered CPA stand loaded into the 12 French Moulin sheath over a balloon that is of pneumatic balloon in balloon 18 into 50 centimeter. And we took the help of also the temporary pacing, because we increased the heart rate to decrease the cardiac output to have a stabilized stent implantation. So as you can see, the stent is implanted, and there is very good intricate flow, as also through the left radial artery, the hand injection also shows that there was no significant jailing of the origin of the left subclavian artery. And the follow-up Doppler also revealed insignificant and the wide diameter of the stent. Let's hear the, okay, it's not running. Now a short discussion on the coarctation aorta. The coarctation aorta can be discrete. It may be preductal, postductal at the site of the insertion of the PDA. They are often associated in children with hypoplasia of the transversors. It is more in male and also female, those who are affected having 30% Turners. And often the coarctation of aorta is associated with VSD, LVOTO, mitral stenosis, aortic stenosis, bicuspid aortic valve, hypoplastic left heart syndrome, complete AVST, tricuspid atresia, and also DORV. The children usually present with, the neonates who are present, usually present with sepsis if they are associated with VSD and other shunt lesions, and usually they have differential cyanosis. The older children and adolescent and adult usually present with this hypertension of the upper limb, and also there is a systolic murmur, ejection systolic in nature. The precoedema also, if the extensive collateral develops, we will also get the continuous murmur at the back or the site of the collaterals. And the diagnostic evaluation, I will not go in details, but you see in case of neonate, if we see that the ECG, we will find right ventricular hypertrophy, but in case of older children and the adults, we will have left ventricular hypertrophy. As you can see in adolescent girl, if the adolescent boy, if there is a long-standing hypertrophy, there may be some T changes also. So the X-ray, in a long-standing cases, we may find the figure of 3 pre and post systolic dilation in a penetrated, and also there will be the notching at the ribs from 3rd to 8th. The echo is diagnostic. We'll see the high flow velocity at the quark segment and also at the diastolic runoff. And every patient who are adult and adolescent must have a CT or MRI to have a complete aortic evaluation. So cardiac catheterization is not indicated for diagnosis. Now the indication of treatment, patients who have gradient over more than 20 millimeter mercury with left ventricular dysfunction or the hypertension, or also if having the diameter of the quark segment more than decreased more than 50% in comparison to the diameter of the aorta at the level of the diaphragm, is indicated for the mode of intervention. In case of neonate, the surgery is the choice, and critically neonate may be bailed out with the balloon angioplasty for time being, and infants for native coarctation surgery or angioplasty, and infant with coarctation balloon angioplasty, and children less than 25 native coarctation balloon angioplasty has to be done, and children less than 25 kilo recoarctation balloon angioplasty plasma stenting is to be done, and children more than 25 kg with a native coarctation catheter-based stenting is the choice of treatment. Children more than 25 kilo and adults recoarctation is the catheter-based stenting is the choice of treatment. So in conclusion, I want to say that coarctation remains the most common aortic arch abnormality in children and young adults. The key to optimal management of this patient is early detection and timely intervention. Over the last 20 years, the usefulness of stents in patients with congenital heart disease have become well established. Stent implantation is now considered to be the safe, effective method of relieving coarctation of aorta not amenable to pure balloon angioplasty. Thus, stent therapy now considered to be the standard and first-line treatment of coarctation of aorta in adults that has been proved in this case also. The lifelong follow-up is mandatory for this patient to monitor for any late complications. Thank you for patient hearing.